The cornea is the clear outer layer at the front of the eye that helps your eye to focus light so you can see clearly. In this episode of OCuTALK, Dr. Aparna Shah will be discussing corneal transplant surgery, when it is needed, the recovery process, and potential side effects. Dr. Shah?
I want to talk to you.
Not now, later.
No, now.
Hello everyone, and thank you for joining us for a brand new episode of OCuTALK. Hello everyone, and thank you for joining us for a brand new episode of OCuTALK. My name's Nick, and today we have a very special guest joining us from Bennett and Bloom Eye Centers, Dr. Aparna Shah. Dr. Shah, thank you so much for joining us today.
Thank you for having me.
Well, again, thank you for joining us. And Dr. Shah, I don't know if anybody really remembers, but you've been on our show before. So I was hoping that maybe you can kind of reintroduce yourself to our audience, let them know a little bit about your background and your specialty.
Absolutely. So my name is Aparna Shah. I grew up in Michigan. I went to the University of Michigan, Ann Arbor for my undergrad education. Then I went on to medical school at the University of Cincinnati. After that, I went back to Michigan and did my ophthalmology residency at William Beaumont Hospital in Royal Oak, Michigan. And following that, I did my cornea, refractive, and external disease fellowship at the Cleveland Clinic in Cleveland, Ohio. And that was prior to joining my current practice at Bennett and Bloom Eye Centers. And we are located in Louisville, Kentucky. And at that practice, I spend my time practicing as a cornea, cataract, and refractive surgeon. Most people know me as a LASIK and cataract surgeon. That's kind of what I'm known for there. But I do spend a considerable amount of time performing and managing corneal transplants as well.
Well, excellent. Again, thank you for that introduction, Dr. Shah. And again, thank you for joining us. It's so good seeing you again. So for our discussion today, Dr. Shah, we were actually hoping we can discuss a little bit about cornea transplants. But before we talk about cornea transplants, could you maybe kind of talk a little bit about the cornea for those who may not know? What exactly is it and how does it work?
It's a great question. So the cornea is the clear dome-shaped structure in the front part of the eye. It's composed of 5 layers. The top layer is a skin cell layer called the epithelium. So it's very similar to the skin that we have on the rest of our body. Below that is a structural layer called Bowman's layer. And below that is the bulk of the cornea, which is called the stroma. Underneath that stroma is a layer called Descemet's membrane, another structural layer. And finally, below that on the innermost part of the cornea is a layer of endothelial cells, one thin layer. Now, the cornea is a clear structure because it's a dehydrated structure. There's no water in the cornea. That's the reason it's so clear. And that's the reason why we're able to have vision the way that we can. So it is the job of that innermost layer of cells called the endothelial cell layer to really suck fluid out of the stroma and keep it clear to maintain its integrity and maintain its clarity. So that is also the basis of corneal transplants, to maintain a clear cornea so that the patient is able to see clearly.
Oh, well, excellent. Thank you for that explanation, Dr. Shah. And so now that we know a little bit about the cornea and how it works, what exactly is a corneal transplant?
So a corneal transplant is when we remove part or all of the patient's cornea and replace it with a donor cornea, again, to restore clarity or integrity of that structure. So the nice part about the cornea is that it's avascular, meaning there's no blood vessels on it. On a normal, healthy cornea, there's no blood vessels. So when you think of a traditional transplant in the rest of the body, most people think of rejection, lots of medications, oral medications, immunomodulatory medications, just kind of a lot of stuff going on in the body. But because the cornea doesn't have any blood vessels, there's no way for those immunomodulatory mediators to get to the cornea and cause rejection and failure. It's still possible, but the risk of that is very low when compared to traditional transplants in the rest of the body. So advancements in our field have allowed surgeons actually to go from replacing the entire cornea now to replacing just part of the cornea. So the part that's diseased or the part that needs to be replaced instead of replacing the entire thing. So this also has decreased rejection rates and has increased success rates.
Well, fascinating information, Dr. Shah. Again, thank you for that information. So Dr. Shah, I had a few questions now just to kind of get into it a little bit, if you don't mind answering them for us. What conditions require a corneal transplant, and when would I need this procedure? Or anybody who's going through this conditions, would they need this procedure? Also, are there different kinds of corneal transplants?
Yes, there are. So there are several types of corneal transplants. Corneal transplants are also known as keratoplasties. Different conditions also require different types of transplants. So let's break it down by type of transplant. So there are largely two categories of keratoplasties or transplants. The first is an endothelial keratoplasty. The second is more of a full thickness keratoplasty. Okay, so we're going to start with the endothelial keratoplasties. So remember, the endothelial cell layer is that innermost layer of the cornea that sucks fluid out of the stroma and helps it maintain its clarity. So the most common endothelial keratoplasties are actually called DMEKs. So DMEK stands for Descemet's membrane endothelial keratoplasty. So the name tells you exactly what portions of the cornea we're replacing: Descemet's membrane and the endothelial cell layer. So this kind of transplant is ideal for conditions that have a diseased endothelial cell layer or Descemet's membrane. So some examples are corneal dystrophies that affect the endothelial cell layer, like Fuchs corneal dystrophy or posterior polymorphous corneal dystrophy. These are both endothelial dystrophies. Other things that can affect the endothelial cell layer is a condition called pseudophakic bullous keratopathy, which is when you have endothelial cell dysfunction after cataract surgery. And then there's a group of syndromes called ICE syndromes or iridocorneal endothelial syndromes. And these also involve a diseased endothelial cell layer as well. So basically, if you have a diseased endothelial cell layer, we can essentially go in and replace just that layer plus the Descemet's membrane right above it. So we're not having to replace the entire cornea just for that one disease cell layer. So that's a DMEK. Now, there's another variation of an endothelial keratoplasty called a DSEK, and that stands for Descemet's stripping automated endothelial keratoplasty. So that's a mouthful, but basically what that is it's the same type of procedure as a DMEK, but it also involves transplanting a small portion of the stroma. So we have a small portion of the stroma, Descemet's membrane, and the endothelial cell layer. So it's very, very similar. The DSEK procedure is a little bit more ideal in patients who have sicker eyes, who've had more of an ocular history, who have other surgeries or have had other things going on with the eye, where a DMEK might be technically challenging to perform. But again, very similar type of procedure. So that's the endothelial keratoplasty category. Okay. So then the second category is the full thickness category. So the full thickness category, we have two types of transplants as well. So the first is called a DALK, which stands for deep anterior lamellar keratoplasty. Again, another mouthful. Basically, that means we're taking the front portion of the cornea, not the inner layer, the front portion, and replacing it with a donor front portion of the cornea. Okay, so that is ideal in conditions where the front layer of the cornea is damaged or is no longer clear, or it doesn't have the structural integrity anymore. So the goal of the DALK is actually to leave the host Descemet's and endothelial cell layer alone. So examples of when we would use this procedure are keratoconus, which affects the bulk of the cornea, other corneal ectasias like pellucid marginal degeneration, or even post-LASIK ectasia, and then stromal corneal dystrophies. So dystrophies that affect the bulk of the cornea and cause the bulk of the cornea, the stroma, to be cloudy or not clear. And then, of course, opacities in the stroma and scars. So that's a DALK. Now, the second type of full thickness keratoplasty is called a penetrating keratoplasty. Now, this is a true full thickness transplant. This transplant, we don't even leave the donor's Descemet's or endothelial cell layer. We take all of it. We take all of that host cornea and we put a brand new one on. The indications are largely the same as a DALK. A DALK is when the patient has an intact Descemet's cell layer or a Descemet's membrane and an endothelial cell layer. It's hard to discern in the office sometimes who has an intact layer and who doesn't. So our goal is we try for adults sometimes, and sometimes we can do one, but sometimes we find in the middle of surgery that they don't have an intact Descemet's membrane. So we switch to a full thickness penetrating keratoplasty or a PKP. But again, the indications for those two are largely the same.
Well, amazing information, Dr. Shah. Thank you so much for breaking all of that down for us. I did want to actually kind of get a little bit into more of I wanted to ask about the surgery itself. So how does the procedure work? What is the surgery like?
That's a great question. So it really depends on the type of transplant. So for a DMAC, because we're removing just Descemet's membrane and the endothelial cell layer, that's exactly what we do in the operating room. We remove the patient's Descemet's and endothelial cell layer, and then we insert a donor endothelial cell layer and Descemet's membrane. The way that it is inserted is the tissue is actually wound up like a scroll. We insert it into the anterior chamber of the eye, and then I use a series of tapping motions on the top of the cornea to unscroll and center that tissue. So that tissue is very thin. It's about 14 to 20 microns in thickness. And if you think of it, a red blood cell in the body is about 8 microns. So it's about twice the size and thickness of a red blood cell. That's how thin that tissue is. So our goal is to get that new tissue in, center it in the patient's cornea, and then I use a gas bubble underneath it to stick that cell layer up against the patient's cornea. So there's no stitches involved in causing that tissue to adhere. It's just a gas bubble that sits behind it. So that's how a DMEC works. A DSEC is very similar, but because the tissue we implant is thicker, we don't have to use a scroll. We just insert it into the eye as a flat structure and then use an air bubble again to push it up. So it's very similar. The endothelial keratoplasty technique, similar, slightly different, slight variations, but overall about the same. Okay. And when you talk about a full thickness transplant, well, if we go to the penetrating keratoplasty or the PKP, that involves removing the entire center portion of the patient's cornea and replacing it with an entire center portion of a donor cornea. And then that graft is actually adhered by 16 sutures that hold that graft in place circumferentially around the graft. And again, a DALK is very similar to that. It's just whether or not we have the Descemet's membrane and the endothelial cell layer there as well. But the general concept is about the same.
Well, very cool information, Dr. Shah. So with all of that in mind, how long does the procedure typically last?
It's a good question. So for a DMAC or a DSEC, probably 20 to 35 minutes, give or take. So not too long. A PKP can be about an hour long, maybe longer, just depending on the surgery. And then a DALK is a little bit technically challenging. So it can be anywhere from 45 minutes to 2 hours. So a DALK can take a little bit longer, but overall, not too long of a procedure overall.
Amazing information, Dr. Shah. And with all that surgery in mind, I know the recovery process sometimes is a little arduous with some of these surgeries, but what is the procedure, the recovery process like for this procedure?
So I tell my patients with the DMAC, I say, listen, the surgery is a piece of cake. The post-operative care can be a little bit tedious. So for the first 3 days after a DMAC, I have my patients laying flat on their back with their nose to the ceiling. And what that does is it facilitates that gas bubble really adhering that tissue to that cornea. So that's the worst part, is for the first 3 days, I make my patients lie flat, nose to that ceiling. And I say every hour you can get up for about 10, 15 minutes, but then I want you right back on your back. So I tell them that's the worst part. Now, after 3 days, if their graft is nicely attached, I'd lower the amount of time that they need to lie flat. So they don't have to lie flat the entire day. I still have them lie flat for a few hours, but that really helps use that gas bubble that's still in their eye. Now, over that first week, the body reabsorbs that gas bubble, so eventually disappears. And once it's gone, of course, the patient doesn't need to lie flat. But again, that first 3 days is really the critical day. A DSEC is similar. Now, they don't have a gas bubble, they have an air bubble. So the air doesn't last quite as long as the gas. but I still have them lie flat on their back to really facilitate adherence of that tissue. Other than that, after that 1 to 2 week mark, pretty self-explanatory. It's not too bad. It's really just that first 3 days that's pretty rough. For a PKP or adult, that recovery is about 6 to 12 months, and it can be even longer sometimes. So 6 months is when I start removing sutures. So remember, there's 16 sutures on that cornea, and our goal is to get all of them off at some point. Now, we don't always get all of them off. Sometimes we leave a couple here and there, but we start removing them at the 6 month mark, and we remove 1 to 2 sutures every 6 to 8 weeks. So based on that timeline, it takes several months to really get to the full healing potential. And but there's no laying flat with that procedure. So there's no positioning required with that procedure. It's more just very frequent post-operative visits and management in the office.
Well, excellent information, Dr. Shah. Thank you so much. And I know with surgery, there could be a possibility of complications.
Always.
So what are the complications that people should know about going into this type of surgery? And what's the success rate of a corneal transplant?
That's a great question. So, of course, any surgery or procedure has its risks. Significant sight-threatening risks are very rare. These are things like intraocular infection or endophthalmitis, retinal detachment, recurrent inflammation. Those are very rare, but they do happen. I'd say the risk is probably about less than 1 to 2% there. So very low. Now, risks that are maybe a little bit more common include graft rejection and graft failure. Remember, we talked about how these risks are relatively lower compared to full body transplants that involve other parts of the body. But that risk is still there. Now, with a DMEC and a DSEC, because we're just transplanting just a small amount of tissue, that risk is very, very low. Very low. Now, it is a little bit higher with a full thickness transplant, but again, very low risk. And I tell my patients this. I do have my patients on a steroid eye drop for an extended period of time to prevent rejection and failure. And that actually tends to do the job quite well, to the point that I rarely even see these things happen anymore. Other risks are graft detachment, especially of a DSEC or a DMEC. That might require adding gas back into the eye to really push that tissue back up to where it needs to be. And sometimes we need to go back to the operating room and just repeat the surgery if that graft doesn't want to stick. And then finally, with a full thickness transplant, there's always a risk of what we call graft dehiscence, because where we've sutured it, that area is naturally going to be a lot weaker than the regular cornea. So you have a higher risk of dehiscence of that graft where it kind of detaches from the patient's cornea. But again, very rare unless there's usually some sort of trauma that precipitates that. And then that would necessitate another trip back to the operating room to really close that back up.
Well, excellent. Good information to know, Dr. Shah. And so before we leave today, was there anything else that you'd like to tell our audience about?
I didn't even actually talk about the success rates. I forgot about that. So the success rates of a DMEC. So at 3 months, the success rate is about 87%. So it's really good. At 6 months, about 85%. And again, about 85% at 1 year. So very high success rates. For a PKP, it varies a little bit. So the data I found is at 5 years, anywhere from 75 to 90% success rate, about 82% success rate at 10 years. And this is for a first-time graft. Each time you go in and repeat a corneal transplant or a full thickness graft, it has a higher rate of failure. So it's because the body's now getting used to the fact that there's something there that maybe shouldn't be. So it's sending as much immune modulatory mediators as it can to try to fight it off. So each successive transplant has a lower success rate, but again, still pretty high when compared to success rates for other parts of the body. And then the other thing to keep in mind is because my patients who've had corneal transplants are on long-term steroid use, topical steroids do have their own side effects. So these patients do need to be seen every so often, even if they're several years out from their transplant, just to make sure that their pressure in their eye is still doing well. They haven't developed a cataract if they didn't have one already. Other things that can be side effects of chronic steroid use. So it's always good to keep an eye on that because, again, those risks are very much so there with chronic steroid use. However, it's an eye drop, not an oral steroid. So risks are a little bit lower there as well.
Well, fantastic information, Dr. Shah. Everyone, that was Dr. Shah from Bennett and Bloom Eye Centers. Dr. Shah, thank you so much for joining us today.
Thank you for having me again. It was a pleasure.